Hello, my name is Zadia Rodriguez and I'll be going over ICU delirium. This topic is near and dear to my heart since I work in an intensive care unit and often see this in my patients. ICU delirium is a disturbance of consciousness and cognition that develops over a short period of time, hours to days, and fluctuates over time. Other names for ICU delirium include ICU psychosis, ICU syndrome, acute confusional state, encephalopathy, and acute brain failure. Remarkably, in every intensive care unit, on any given day, more than half the patients will experience acute changes in cognition and consciousness that reflect the presence of delirium. Delirium is a preventable medical condition that is a syndrome of acute brain dysfunction. It occurs in 60 to 80% of critically ill patients who are receiving mechanical ventilation, and in 20 to 50% of critical ill patients who are not receiving mechanical ventilation. These percentages mean that more than 40,000 patients receiving mechanical ventilation in an intensive care unit in the United States experience delirium every day. Delirium continues to plague patients across the care continuum, often resulting in an increase in morbidity and mortality and a longer hospital stay. As one of the 6 leading causes of preventable injury in patients aged 65 years or older, delirium adds approximately 10 days to the patient's mean length of stay in the hospital. Each additional day spent in delirium is independently associated with a 20% increased risk for prolonged hospitalization and a 10% increased risk of death. Delirium remains unrecognized in 66 to 84% of patients in ICU, acute care, and emergency departments, and is underdocumented and undertreated. The national approximation may be grossly underestimated, resulting in poorer outcomes for patients, higher costs, and a staff shortage. As healthcare braces for the anticipated surge in aging patients, the incidence of delirium is expected to soar. ICU delirium is typically classified in 2 categories. There is hypoactive, which is shown as decreased responsiveness, withdrawal, apathy, and hyperactive, which is agitation, restlessness, and emotional liability. Clinical manifestations of ICU delirium include disorientation, impaired short-term memory, impaired visual spatial ability, reduced level of consciousness, preservation, sleep-wake cycle disturbances, irritability, hallucinations, and delusions. As with ICU delirium, we have to assess our patients for any risk factors that can be modified and not. So some risk factors include increased age, alcohol use, male gender, living alone, smoking, renal disease, length of stay, fever, medicine service, lack of nutrition, hypotension, sepsis, metabolic disorders, tubes and catheters, and so on. Possible solutions for ICU delirium include prevention. The best picture of patient's mental status will come from assessing delirium serially throughout the day, once per shift, with either ICU, CRAM, or ICDSE. Treatment. First, we would go with non-pharmacological, which is reorientation, early mobilization, removal of catheters and physical restraints, early correction of dehydration, scheduled pain management, and minimization of unnecessary noise and stimuli. Also, looking at the treatment as a pharmacological side, we would identify any current medications that might be causing or exacerbating the delirium. As we have come to appreciate the consequences of ICU delirium, research has begun to answer key questions about how it can be assessed, prevented, and managed. A valid and reliable method to measure delirium is an essential component of a delirium quality improvement program. Sensitive and specific delirium screening tools that incorporate tests for inattention have been developed, and they have repeatedly demonstrated high inter-rating reliability and been validated across a wide range of patients in ICUs. Delirium screening takes seconds to minutes and has been successfully implemented within quality improvement programs and routine clinical area, and it is our belief that every ICU patient should be screened daily for the presence of delirium using a validated tool. The 2 main validated tools that you will see in ICU is the CRAM ICU, which is in the first picture that is seen, and it is a two-step process. And then the second one is the ICD-SC checklist. Both of them require you scoring a patient, and off of that score, we would determine if the patient is at risk for delirium or is in delirium, and we can go from there on patient management. With utilizing resources, we have to understand where we can get reliable information about ICU delirium. So certain websites that you can use are the American Nurses Association, the American Delirium Society, and the American Association of Critical Care Nurses. All of them are up to date and frequently upload new articles in regards to ICU delirium and stressing on the importance of prevention. And these are my resources. Thank you.